Hello, hello, hair and makeup done. It is time. Just doing the finishing touches of the outfit. 7 o'clock. It is time for this. What is this? I hear you say. Well, I can tell you what this is. This is a Q&A with yours truly, Jonathan Staiano. Got some questions. Very happy to have interaction. Olivia's straight in with interaction here, saying, hope I can watch live, but not sure yet. See you Friday. Otherwise, decaf for me. I've found on replay the sound goes halfway through. Decaf for me. Look at that. She's putting your order in. That's good. We've thought about that, asking people what sort of drink they want, so we've got it ready when they come. But thank you for that, Olivia. Decaf. Crikey, have we got decaf? I'm pretty sure we have got decaf at the clinic. So if you have any questions, please chip in, and I would be very happy to answer it live if I can. And just please comment and share, as the thing says. So I got some questions preordained, and if you have an input on them or have anything new you want me to talk about, then please feel free to mention it. Straight in at number one, we've got LA versus GA for gynecomastia. Question for the Q&A. I see that some surgeon, nice to have a bit of gynecomastia on there. Thank you for a gynecomastia question. I see that some surgeons seems to opt for local anesthetic rather than general for gynecomastia. They seem to advocate cheaper costs and better recovery. If it's that much better, why does everyone not choose that method? Any pros, cons in either method? Thanks in advance. What a good question. What a good question that is. Wish I'd thought of that. Right, get yourself comfy there. Wheel yourself in. Absolutely right. Now, anytime one person says one thing's better, then you've got to think, why doesn't everyone do it that way? So LA for gynecomastia. Now, there's LA, as in local anesthetic. There's local anesthetic, which means an injection in the area to numb the area. That's sort of pure local anesthetic. And there's local anesthetic and sedation. Two different things, really. When you combine local anesthetic with sedation, it's a slightly different thing to just pure local anesthetic. So I would say that gynecomastia pure LA, pure local anesthetic, is pretty rare. So I have done revisions. I did one not that long ago, and I believe we videoed it. Oh, should I put the link? I should put the link and all that sort of stuff, shouldn't I? Anyway, you interested? Anyway, I believe we videoed it. What happens when I change my web page? Do you guys still see me? So and that was really just the revision. It's a patient who'd had gynecomastia correction already, and he had a little bit of breast tissue just behind the nipple, which I then went and removed for him under local anesthetic. Now, that was pure local anesthetic, and that was obvious. Well, that was free because he didn't. He had surgery by me before, and I don't charge for revisions, and that was a revision. But if it was a paid for procedure, it would have been a lot cheaper than a standard gynecomastia because that was under pure local anesthetic. So that's just me and the patient, and it would have been a lot cheaper. I think it was this one, was it? Not sure if it's this one, but I think this looks like it could be the one. So that would have been a lot cheaper if it's under pure. Back in the room. I don't know if I went then. Did I go? Did I go and come back? Oh, what is gynecomastia? Oh God, right. I'm not making. Sorry, I'm not. Can I do this? Can I do this? Oh, here we go. Here is the video. Actually, you may not want to watch this video because it's like of gynecomastia under LA. Is that going in the chat? I think that's the video anyway. Gynecomastia, good question. What is gynecomastia? So gynecomastia is excess breast tissue in a male. So it's a male breast reduction. Gynecomastia correction is a male breast reduction. Man boobs, moobs, whatever you want to call it, excess breast tissue in a male is called gynecomastia. So men who don't like the having excess breast tissue, then they have gynecomastia correction. So as I say, if it's just a tiny little bit of breast tissue behind the nipple, you can do that under pure local anesthetic. In my experience, it's never that. That's only the one that I've posted there is just a patient who had a little bit residual gynecomastia tissue after having full-on gynecomastia correction. So in my experience, gynecomastia correction needs a more extensive operation that can be done under pure LA. So for me, gynecomastia correction is going to be either LA and sedation, which is also known as twilight anesthetic, if you've heard of that, or GA. And there are definitely pros and cons of it, but one of the pros and cons of LA and sedation versus GA is not cost. It is not cheaper to have it done under LA and sedation than GA, and this occurs for other breast surgery which needs LA and sedation. So cost is not a factor because it's the same price if you have LA and sedation / twilight anesthetic, same thing, versus GA. The reason being that you still need an anesthetist. If you do pure LA, if you're just injecting local anesthetic, you don't need an anesthetist. I do the local anesthetic, and it's just, as I say, it's just me. You don't need an anesthetist. You don't need an operating theatre. Or at least you don't need an anesthetic machine with a ventilator. You just have we have a minor operating theatre at the clinic, so we can do local anesthetic cases there. But we don't need a full-blown operating theatre where general anesthetic cases are done. So LA and sedation is different to pure LA, and so I would say to you that so cost isn't an issue in terms of LA and sedation versus GA. The main issue in terms of LA and sedation versus GA is patient selection. And when I talk to someone about surgery like gynecomastia, like breast augmentation, I usually talk about GA, to be honest with you, because it's a little bit uncomfortable. It's quite invasive. You're operating on quite a large area, whether it be a male or a female breast. Although men say that the gynecomastia is just a little problem behind the nipple, it's usually part of more of extensive area that you need to feather in. If you just take the breast tissue from behind the nipple and you don't do anything else to the rest of the breast tissue in the man, then you can end up with a dent and contour deformities. So usually what gynecomastia correction involves is cutting out that dense breast tissue, that glandular tissue behind the nipple, which is a localized thing, and then liposuction to the rest of the breast to feather it in, to contour it, so you don't just get a sudden dent. And the liposuction is a little bit uncomfortable. It's a little bit uncomfortable. There's a bit of pushing and pulling, and is something that can be done under local and sedation, but the patient has to be up for it. The patient has to be on board with it because it is a little bit uncomfortable. And to be honest with you, often it's just as easy to do it under a GA, but there is less of a recovery. You do feel less of a hangover effect with a LA and sedation. We tend to do it in theatre, in main theatre, so we can always convert to a GA if required. So you can have it done under LA and sedation, but the default position, if you like, is a GA, and mainly because it's a bit uncomfortable. So the pros and cons are it can be a bit uncomfortable if under LA and sedation, but the recovery is quicker. Having said that, the recovery after a GA for a gynecomastia usually isn't too bad, but as I say, it is a bit worse than if you had a LA and sedation. And cost is not a factor. If you are talking to someone who is talking about pure LA. One of the sayings we've got in plastic surgery, or maybe it's just in the world, is if all you've got is a hammer, everything looks like a nut. Why was I thinking about nuts? Everything looks like a nut. Can you hear what's going on behind me? I think the dog has just eaten the dinner off the dinner table. Sorry. If all you've got is a hammer, everything looks like a nail, not a nut, a nail. We'll just copy that bit out when we do it live. Yeah. Cut the nut bit out. Yeah. So you could be a bit careful. If someone's just doing under LA, it might be that they can only do it under LA. They haven't got any GA facilities. They haven't got practicing privileges in a hospital where they can do GA. That's what would worry me if someone's doing gynecomastia under pure local anesthetic. Having said that, if they are doing it and they've got good results and they've got happy patients, then who am I to say? It might be that it's okay to have it done like that way. So yeah, I think we covered that. Julia Jeeves, thank you. What is going to go? Okay, you're very welcome. Helen's got a question. This is what we want. When Helen's done a double question, look at that. Is it the same? When removing 15-month-old polyurethane implants for smooth implants, is it simple exchange or is it more involved? And can you do this? Finally, the prior giving me the go-ahead to choose a surgeon. When removing, is it simple exchange? Okay, it's the same question. It is. Is it simple exchange? Well, it depends, Helen. It depends, and it depends on number one: is the shape of your breasts. Are you happy with the shape of your breasts? Are you happy where your implants are sitting? Are you happy with how everything's looking? Because if you're happy with how everything's looking and it's just a pure exchange of implants in that one implant's out, next implant's in, they're going to be about the same size. That will be relatively simple. The thing I think you're alluding to there is that polyurethane implants are difficult to remove. So people worry about that. They're not that difficult to remove. They are a little bit more difficult to remove than silicone implants. So they are a little bit more difficult to remove, but it's not that bad. So I wouldn't worry too much about the difficult to remove thing. That's fine. But you have got to be a bit careful if you've got to, not careful, but if you're changing size of implants, if you're adjusting the pocket, then that does make things a little bit more involved. But still, it's fine. And the smooth implants would probably want a slightly tighter pocket. Well, not probably, they would want a slightly tighter pocket than the polyurethane implants, because polyurethane implants, as you probably know, become integrated with the tissues, whereas smooth implants don't. So smooth implants, you're looking at a hand in glove fit. Smooth implants, you're looking at sort of like a fit the size of the implant, whereas a polyurethane implant, you make a much bigger pocket. When you take an implant out, especially if you're doing anything to the capsule, then the pocket is maybe larger, unless you're putting a larger implant in, which would maybe take up that space. But you might have to close the pocket down or do little bits and bobs to the capsule, as you usually do some kind of bits and bobs to the capsule, but nothing too drastic. But I wouldn't worry too much about it, Helen. Great news that Priori have given you the go-ahead to choose a surgeon, and should be good. Oh, here we go. Sorry, Helen's back in. We should. Olivia's here, everyone, but just for a few minutes, just so you all know. Helen, I have 275, but looking to go to 380, 400. Okay, so that's fine. So you're going a bit bigger. So yeah, okay, that's good in terms of changing implants, because it'll fill up the space a bit. Sounds good. All sounds good, Helen. On paper, it should be pretty straightforward. But as I say, it's always a bit of not always a bit of a faff, but it's a little bit of a faff taking in polyurethane implants out. But I wouldn't worry too much about it. It's not that bad. So that is good. And talking of polyurethane implants, my polyurethane breast implants feel hard. So this is something from a patient of mine who's had polyurethane implants and says, and is, well, should we go so far as to say doesn't like them? Feels that they feel hard, and she's like a couple of weeks post-op, and basically doesn't like them. And this is an issue with polyurethane implants. And polyurethane foam implants are silicone implants with a foam coating around the outside, and the scar tissue grows into that foam coating in a three-dimensional way. And that means that when the scar tissue contracts, as it always does, it contracts in different directions. And so it's less likely to contract around the implant and form a hard shell around the implant, so-called capsular contracture. So capsular contracture is a lot less with polyurethane implants because the foam is a three-dimensional structure, and the scar grows into it, whereas a textured silicone implant is just like rough. It's not a three-dimensional thing. It's just well, I suppose it is three-dimensional, but it's just rough as opposed to a foam matrix. So for that reason, for the same reason why they're good, they're bad, because there's more scar tissue around them because it sort of grows into the foam. So the implants do feel firmer than their silicone counterparts to start off with. They feel firmer, and patients sometimes don't like that. You can feel the edges of them. And I normally tell people it takes about a year for it to settle. So it is not a quick thing. So this patient's 2 weeks post-op. And I'm like, oh God, it's going to take a year for that to settle. So it's, it is a tough thing in the first year, because they do sometimes, not always, but feel a bit firm, sometimes feel the edges. So I always say to people, if you're worried about that, so to this patient, I would say, don't worry about it. Let's just push through and let's get you through this, because when we're through this, they're better in the long term, but it's more difficult in the short term. And for people thinking of having implants, if they think they don't fancy that, I'm like, fine, have silicone implants, and then if they go hard, you can always change to polyurethane implants. However, when you do that, when you have people have capsular contracture, and you say, I've got these really good implants, they don't go hard, and then you put in polyurethane implants, and they say back to you after a month and say, these are rubbish, they've gone hard already. They haven't gone hard already. They just feel a bit firm to start off with and then soften. So that's another important thing to be clear about, what to expect. But they're not without their issues. And so it's all about informed consent and making the best decision you can at the time. But push on through. Push on through. 3 weeks after brachioplasty, pain and swelling. 3 weeks after brachioplasty, how much pain is normal, and is occasional swelling normal? Yeah, I mean, 3 weeks after anything is really early, really early. So I would not worry about stuff like, well, I shouldn't say I wouldn't worry about stuff like pain and swelling, because obviously it's a bit of a worry having pain and swelling. But things are going to be a bit uncomfortable and things are going to be swollen. And I normally say you're going to have bruising maybe for a week or two, swelling for a month or two, pain. Hopefully it's not pain at 3 weeks, and hopefully it's sort of like discomfort. But this surgery, it's all like tight, and it feels tight, and it feels weird, and it feels numb, and it feels overly sensitive, or it feels, sensation feels abnormal. And the swelling can go up and down. That's people often think it's going to be like really swollen to start with, and then it's going to go down. But what happens is when you first have the surgery, it's like really tight, really swollen, really uncomfortable. And then you've got your compression on, and you've got your, you don't do much because it's really uncomfortable. And you say, oh, I'm not going to do anything. So the swelling goes down, and you think, I actually feel a bit better, especially around the 3 week mark. You think, oh, you know what? I feel good. I'm feeling good. I'm going to start doing stuff. And you start doing stuff, and then the swelling goes up, and you think, oh, flipping it, the swelling's gone up. I feel really uncomfortable. So it does go a bit up and down. So it's not like the swelling just, is maximal at the time of surgery and goes down. It goes up and down in the first few weeks, first couple of months, really. It goes up and down. But that doesn't mean that doesn't mean you shouldn't do stuff. I think it's good to do stuff, but just don't overdo it. And if it does swell, that's your body saying, look, back off, take it easy. So listen to your body. If it's uncomfortable and if it's swelling, listen to your body, back off, and see how you feel. But I think it is good to do stuff. So it's about getting the balance. But at 3 weeks, yeah, it's not unusual to get pain and swelling at this stage. So don't worry about it. The thing to worry about in general in any procedure which is bilateral, so when you're having surgery on both sides, is disproportionate symptoms on one side. So if one side's very painful, if one side's very swollen, if one side's very red, I'd be thinking, hold on a minute, there's something going on here. And that's when you really need to go back and see your doctor. So if one side is a problem, then you need to start worrying. If both, because we often say if it's painful, swollen, red, tender, it could be infection. And then patients come back after a week and say, oh, it's a bit tender, it's a bit red, a bit painful, a bit swollen. And you're like, yeah, but it's fine. And you said, yeah, but those are the signs of infection. They are the signs of infection, but they're also the signs of inflammation and healing. So it doesn't necessarily mean it's infected just because it's painful and swollen. So if you're worried, go and see a doctor. That is the bottom line. If you are worried about things, go and see a doctor. But the main things are you will still have pain and swelling at 3 weeks, and look for unilateral signs. If one side's a lot worse than the other, think, oh, what's occurring? This is a biggie. Smooth versus textured implants, a biggie. How long you got? How long have you got? Right. Well, right. I have here a prop. This is a textured implant. Can you see? Bit rough. I haven't actually got a smooth one. Got one in the clinic, but I've got one here. So textured implant. So we're talking about breast implants here. We used to just use textured implants, and polyurethane implants are in the same group as textured implants, or rough implants, if you like. The surface is rough, and they're rough to break up that scar tissue that forms around the implant, to make them less likely to cause capsular contracture. So as I say, polyurethane is the best because it's a three-dimensional structure. Textured implants are trying to mimic polyurethane by making it a bit rough to try and break up that scar tissue so it doesn't form a sheet of scar tissue around the outside. So in those terms, textured implants are better than smooth implants, which are just like glassy smooth. It's like a marble, because the scar tissue forms around a smooth implant. It's more likely to go hard and form a hard shell around the implant. So basically, when they first made implants, they made them smooth, and then they evolved them with texturing to try and reduce the risk of capsular contracture. Why the question, you might say? Well, the question is because smooth implants are coming back in now, and I wonder if this is why Helen's going from polyurethane to smooth, because smooth implants are now coming back in, and some surgeons are using them more, and some countries have banned textured implants because of ALCL. ALCL is a type of cancer associated with implants. It's a very rare cancer, so it's obviously, cancer, big emotive term. It's a very rare cancer, and it is curable, to put it in some perspective. So the risk of ALCL is very low, and if you were unlucky enough to get ALCL, the risk of curing it is very high, usually by removing the capsule. It's a cancer of the capsule. To be honest with you, the numbers are so small, we don't really know a huge amount about it. There's a lot of research going on about it, but it seems to be related to the texturing of the capsule, of the implant, the roughness of the implant. And it used to be that there were no cases with smooth. There are some cases with smooth now, but it's a lot less common with smooth implants compared to textured implants. So on that, it's a bit like the GA in LA with the gynecomastia, pros and cons. Smooth implants are less likely to cause ALCL than textured implants, but more likely to cause capsular contracture than textured implants. Balance. Smooth implants don't really adhere to the tissues. You can't get teardrop shaped smooth implants because they just move all over the place. They don't adhere. So there are some bad things about smooth implants. As I say, that's how they first made them, and then they evolved into the texturing and the polyurethane, but they're less likely to cause ALCL. So a lot of people feel happier with that, and that is fine. But as I say, it's about informed consent. It is about weighing up the pros and cons and being realistic about the pros and cons, because realistically, you've got to be aware that the risk of ALCL is extremely small. But if you would feel more comfortable, then you should have smooth implants. I would say, personally, I think we need to tell people put it in perspective and give them the perspective of risks, because at the end of the day, we deal with risks all the time. They looked at the risk of going skiing and driving in a car, and it's similar. Your risk of dying from going skiing for a week is more than your risk of having textured implants for life. But people wouldn't think twice about going skiing for a week, even though we know in the back of our minds there's a risk of death. It's a very small risk of death. Well, it's the same for having textured implants in. But for some reason, I think we find it easier to accept the risk when we go skiing, or when we go drive in a car, or if we drink, or if we smoke, or if we use sunbeds, or or do anything really, to be honest with you, live, eat barbecue food, cross the road. Anyway, so yeah, there's risks with everything. So it's about putting it in perspective. But as I say, if it is obviously an emotive thing, and some people think I don't want that. I want smooth. Fine, you can have smooth, but you have to accept that they were the original implants. They have got some limitations in terms of the lack of adherence with the tissues, increased risk of capsular contracture, more likely to move about. The good thing about them is that if they do move about, because they haven't really got as much structure as a textured silicone implant, it doesn't matter quite so much. You often don't notice it if it moves about, but obviously they can't come as a teardrop shape, but still, that's a balance. It's all a balance. Life is a is a balance. It's not really a balance, but it's a you know making decisions. Yeah. So I hope that's helped you make your decision with smooth versus textured. I tried this the other day in the clinic with a patient, and I didn't do a very good job of it, to be quite frank with you, talking about the risks of implants and risk of dying in the car and things. It didn't go well, so I hope I did a better job there, but I'm reflecting on it. I'm trying to refine my technique when I talk to patients about relative risks. I don't want you to think that there's a doom. I don't want to be a doom bringer, doom doom mongerer, but it's about realistic risk management. Yeah, risk management. That's what I'm talking about. What is going on? We got any questions? Julia, you're funny. Julia, thank you for that. You got any questions, Julia? You already come in with one. I'm not going to have a go at you because you've already had the gynecomastia one. So you have had a question. Amanda, good to see these live sessions. Good to see you, Amanda. Thank you for that. Very kind. Nice to have a bit of support. You do wonder, because let's face it, what am I doing at the end of the day? I'm sitting here looking at the thing, and thank you for that. That's what we want. A bit of positive feedback. Thank you, Amanda. Look, Amanda and Julia and Helen and everyone. I'm out of questions, guys. I see it. I had 4 questions. Sometimes I had 10. Been in double figures in my heyday. I got 4. That's okay. 4's good. 4 good. I've got to be honest. There were 4 good questions. I think you'll agree with that. Not to mention Helen. I shouldn't. Helen and Julia both chipped in. But if you've got any questions, I will be around for the next few minutes. So if you have any questions, then please ask. I will be around for the next. Obviously, I've got something to do a bit later on, but we'll be around for the next few minutes. Oh my lord, look at those cobwebs. So Khan's in the house. Hi, Khan. How you doing? We're just wrapping up. Oh, Amanda's got a question. Weird one. Weird question. Even better. This is a weird one, but I don't know the difference between teardrop and round. What's the difference with look? That's a good question. Khan's failed. Khan, stop it. Stop it. We got some crackers in this week. Right, Amanda, that's a good question. And you know what, Amanda, that is a good question, because some people would say there's not much difference. I think there is a difference, but the main difference, you see, what happens when you have this is a round implant. You see, it's like dome shape. Can I get the thing right? It's like a dome shape. It's not round. It's like a dome shape. But when you hold it up, can I do this? Can I hold it up? I can't hold it up. It goes a bit fuller in the bottom. Does that show? No. To be honest with you, it's not really doing it, that one, is it? That's just staying round. Depends on how cohesive they are. Sometimes they... Is that going a bit fuller in the bottom? Anyway, so much for that demonstration. Anyway, that's some people say that round implants, gravity, they go a bit less full in the upper pole. But the bottom line difference is that teardrop implants are less full in the upper pole than round implants. So sometimes people say teardrop implants give you a natural look, but that is not always the case, because you've got to look at the breast you got and add it to the implants. It's not all about the implants. That's why you've got to do this sort of stuff with a surgeon. You do too much online and you start getting people saying, oh, round implants give you a fake look, teardrop implants give you a natural look. you can get a natural look with a round implant and a fake look with a teardrop implant, looking at different profiles and different breast shapes. And it can be a bit confusing. But broadly speaking, it's less full in the upper pole with a teardrop implant than it is a round implant. For a given base width, a teardrop implant is slightly smaller, and a teardrop implant has got a risk of rotation. For me, and in my practice, teardrop implants really come in when you haven't got hardly any breast tissue at all. When we're doing reconstruction, people who've got cancer, we always use teardrop implants because there's no breast at all. So if you've got no breast tissue at all, the shape of the implant's really important because that is the shape of the breast. When you have got some breast tissue, particularly if you've lost volume in the upper pole and your breast has descended a bit, then a round implant can sometimes give a bit of fullness in the upper pole and give a bit of projection in the lower pole and can give you a natural result. So it really depends on the breast shape, the projection of the implant you're choosing, the volume of the implant, and what have you. So that it does depend on things. For me, a teardrop really comes in when there's no breast tissue at all. But that's the difference. It's a less full in the upper pole with a teardrop implant. And the other thing I would say to you, Amanda, people get really hung up on this stuff, but I wouldn't get too hung up on it. You can get good results and bad results with round and teardrop implants. It's not everything. The implant choice is not everything, although everyone does worry about it. I say it, but people always still do worry about it. Try not to worry about it. If you are considering implants, try not to worry about it too much, because it's like, as long as you get the width right and you don't get a crazy, the wrong projection, you don't get it sticking out too much, you should be all right. So, losing weight brings on challenges, especially in the lady region. I would like to know what can be done to loose flaps. It's all gone quiet behind me. I hope my children didn't hear that. God. Loose flaps. Sorry for the wording. Okay. Oh, here we go. Vilma says hi. Hi, Vilma. Lovely to see you here. Julia's back in. Sorry for my wording. The vaginal lips. Okay. Well, let's just I've got to just keep it down a bit here because I have got children in. So, whoa. Okay. Right. So the vaginal lips are, I think there, Julia, is the labia. Now, the labia tend not to have a big effect on weight loss. The weight loss is more the mons area, which is the bit where the pubic hair is a bit above. That's where weight loss can give a bit of ptosis or a bit of droop to the mons area, which is not the vaginal lips. It's the bit above it where the bulk of the pubic hair is. The labia can be enlarged and that can be fixed. That's relatively simple. It's called a labiaplasty. I don't do it. But we've got Kirsten at the clinic. We've got a female plastic surgeon who does that sort of thing, who does labiaplasty, and that's relatively easy to fix for the what you might call the vaginal lips, but it's call it the labia, those bits. If they are too big, and if you get chafing, and if they're in the way, then that can be fixed. But I'm not really aware of it being a massive problem with the losing weight thing. I think usually losing weight is more the mons. But again, the mons can be fixed as well, can be tightened, can be lifted. Got to be a bit careful with the mons lift because you can bring up the clitoris and cause problems. But getting into a little bit, don't know what we've got a watershed. We're probably a bit below the watershed. Got to be careful with the wording. Oh, wait a minute, what's going on here? It's all kicking off. Amanda, thank you. I'm coming to see you soon. I also have Khan to thank, as it was this person who mentioned you and your book. Thanks, Khan. I've got a Khan to thank as well. Thank you, Khan. Julie said, oh, she's had a Mons lift. Oh, you've had a Mons lift? Okay, well, there you go. You had a Mons lift. God, you're a pro. So, okay, well, then if it is the labia, then that's a labiaplasty. Relatively simple procedure, a labiaplasty. Yeah, that's something that can be done. As I say, we've got someone at the clinic now who does that. I don't do it, but it is something that Kirsten does. So that is, she's a plastic surgeon. She could see you, or whoever. You could see other people. It's a relatively common procedure. It's called a labiaplasty, LABIA plasty, relatively common thing to have done. So so Amanda's going to see me. That's fantastic. Looking forward to seeing you, Amanda. Julia's had a Mons lift, and Khan is my top fan. Look at that. Lovely comments in the comment section there. So that was a good one, Julia. You pulled that one out of the bag, as it were. Hope that has been helpful. I should do this again. This hanging around for more question. I hang around. Oh no, I'm not going to hang around. Oh, Amanda's off. Okay, Amanda, you off now. Thanks for your time. See you next week. I will see. Does that mean you're coming to the clinic next week, or you see me here next week? Either way, I will see you next week, Amanda. I will be here 7 o'clock, and I'll also be at the clinic next week and this week. Yeah, Julia, thanks. Yeah, not my area, Julia. Really, I think I made that quite clear. But yeah, it is a bit. Yeah, I'm okay. I'm a professional, Julia. I'm a professional. I think you can tell that by now, and I can take on these questions and I can run with them. So don't worry, Julia. I will take on any question, and I will be able to manage it. So I think I demonstrated that earlier. So thanks for your questions, Julia. Very, very happy for you to ask me any questions. And you know what? We put this on YouTube, and they keep on saying I sort of go on a bit. Can you believe that? I can't believe it myself. But so I've got to maybe try and be a bit more succinct. Reflect on that and try and be a bit more succinct. But yeah, thank you, Julia. I'm going to now end the broadcast. You know what I'm saying? I'm just going to finish it. I just got to have a good ending. I've got to think about a good ending. I know what. That's all I got time for. Should I say that? That's all I've got time for. It's not. I could stay as long as you want, but I'm going to say it anyway. That's all I've got time for, folks. Thank you for watching. Thank you for visiting. And I'm going to end the broadcast. And I hope to see you next week, 7 o'clock, right here. Get your questions in and I will answer them, or you can ask them live. No more ramblings. Broadcasting ending. Thank you.